Good day, everyone, and welcome to the Association of State and Territorial Health Officials PHAB Domain 6 webinar series. Today's conference is being recorded. At this time, I would like to turn the conference over to Jamie Ishcomer, Senior Analyst of Quality Improvement and Performance Management. Please go ahead.
Thank you very much. And on behalf of the Association of State and Territorial Health Officials, aka ASTO, I would like to thank you all for participating in today's webinar, Updating Public Health Laws for PHAB Accreditation. This is the second of a three-part webinar series ASTO is hosting on the Public Health Accreditation Board's Domain 6 Public Health Laws. My name is Jamie Ishcomer, and I'm a Senior Analyst of Quality Improvement and Performance Management at ASTO, and will be moderating today's session. For those that may not be familiar with ASTO, ASTO is the national nonprofit organization representing public health agencies in the United States, the U.S. territories, and the District of Columbia, and over 100,000 public health professionals these agencies employ. ASTO's vision is a state and territorial health agencies advancing health equity and optimal health for all, and our mission is to support, equip, and advocate for state and territorial health officials in their work of advancing the public's health and well-being. Today's webinar is brought to you through funding and partnerships between ASTO and the Centers for Disease Control and Prevention, proposed Center for State, Tribal, Local, and Territorial Support. The content of this webinar are those of the authors and do not necessarily represent the official position or endorsement of the CDC. Before we begin, here's just a few quick notes on logistics for today's webinar. First, all lines are muted and will remain muted for the remainder of the call. We will have time for questions at the very end of the webinar, and questions can be entered into the chat box. I ask you all that if the question is for a specific individual, please include who that individual is. If you are sharing a conference room or computer with others, I ask that you please use the chat box to provide each person's name, organization, and email address to ensure that they also receive future announcements regarding the webinar series and the recording. There will be a brief evaluation at the conclusion of this webinar, and I ask that you all please take a few minutes to complete this as it helps ASTO ensure our own continuous quality improvement. And finally, you all have already received the slide deck. But both the slide deck and recording will be posted on ASTO's website within the next week, and you will receive an email notification once that is available. Here's a quick look at what you can expect from today's webinar. I will quickly introduce each of our acclaimed presenters before turning it over to them. You'll first hear an introduction to PHAB Domain 6 and Standard 6.1. focused on reviewing existing laws and work with governing entities and elected appointed officials to update them as needed, presented by Lea Silva, the Director of State and Territorial Performance Improvement at ASTO. She will then turn it over to Katelyn Lange from the Washington State Board of Health, who will talk about her health impact review work and share strategies for assessing public health laws and engaging with stakeholders, elected officials, and subject matter experts. Finally, we'll hear from Dawn Hunter from the New Mexico Department of Health, who will discuss her work to update New Mexico's Public Health Code and her agency's efforts to continuously review and update public health laws. And again, we will have time for questions at the very end of all three presentations, and please use that chat box feature to ask those. And it's a quick reminder that we will have a third webinar on updating public health laws for PHAB accreditation on May 23rd from 2 o'clock to 3:30 p.m. Eastern time. And with that, I would like to quickly introduce each of our presenters. First, we have Katelyn Lange, who is a health policy analyst at the Washington State Board of Health, where she's responsible for conducting health impact reviews, a tool she will describe during today's webinar. Prior to joining the Board of Health, Kate worked with the Washington State Department of Transportation to examine policies, performance metrics, and process-related products, with the potential to improve the agency's ability to incorporate public health considerations within planning and project development. She has experience conducting quantitative and qualitative research on a range of topics related to the social determinants of health and equity. She is particularly interested in how built environment and education policies influence health equity. Kate earned her bachelor's degree in public health from the University of California, Berkeley, and her master's of public health degree from the University of Washington, Seattle. And joining Kate, we have Dawn Hunter, who is the Deputy Cabinet Secretary for the New Mexico Department of Health. In this role, she has oversight of 4 program areas, including public health, epidemiology and response, the state laboratory, and health facilities licensing and oversight. Dawn is a former policy director and continues to oversee the policy office. Dawn first joined the New Mexico Department of Health as a visiting attorney in public health law through the Robert Wood Johnson Foundation Visiting Attorney Program. Prior to this, Dawn was a microbiologist in the Advanced Biosensors Laboratory in the Center for Biological Defense at the University of South Florida, where she specialized in researching and developing biosensor assays for the rapid detection of food and waterborne pathogens. Dawn also has experience in residential foster care, child protective services, and foster care adoptions. Dawn has an AB in English Literature from Princeton University, a BS in microbiology, and an MPH in global communication disease from the University of South Florida, and a JD from the Stetson University College of Law. She is a member of the Florida Bar and is certified in public health by the National Board of Public Health Examiners. And finally, we have Lea Silva. Lea Silva joined the Association of State and Territorial Health Officials, or ASTO, in 2016 and serves as the Director of State and Territorial Performance Improvement. In this position, Lea works with territorial and freely associated state health agencies to strengthen the public health infrastructure and build agency capacity. Lea manages ASTO's relationships with external partners in the Pacific and Atlantic and coordinates all of ASTO's programmatic work in the territories and freely associated states. Lea is responsible for the content, design, and implementation of project deliverables around business process improvement, strategic planning, performance management, quality improvement, and accreditation readiness in the territories and freely associated states. Prior to joining ASTO, Lea was an RWJS Public Health Law Fellow at the Minnesota Department of Health. She earned her bachelor's in political science from the George Washington University and her law degree from Penn State Law. And without further ado, I would like to turn it over to our first presenter, Lea.
Thank you so much, Jamie, and thank you everyone who joined the second webinar in this series. My role today is to provide some background on Domain 6 and Standard 6.1, updating public health laws. Before we get into the specific Standard 6.1 that we will be focusing on today, I'd like to highlight some key points about Domain 6 overall. And some of these points were raised by Robin Wilcox of PHAB during our first webinar. But if you weren't able to join our first webinar, I hope this provides a good starting point for you. And I encourage you all to listen to that first webinar. If you weren't able to join, it's on ASTO's website. And if you would like that emailed to you, please let us know. You can enter that into the chat box. So first, even though Domain 6 is called Enforce Public Health Laws, enforcement is just one part of the standards and measures in Domain 6. In addition to enforcement, PHAB addresses the need for public health expertise within health departments to influence laws and regulations. So public health officials and public health staff must have expertise on public health laws and how those laws impact the public's health. It's also about sharing that expertise with the community, stakeholders, and decision makers at all levels. Second, while the title of the domain is laws, the health department's documentation for accreditation can relate to statutes, regulations, rules, executive orders, case law, and codes, etc. We also have contracts and MOUs on our slide here. Really, we're looking at any kind of documentation that holds the authority of law and is enforceable by law. So again, thinking broadly about what are public health laws. Finally, in Domain 6, PHAB encourages health departments to use a broader definition of health. So when you're assessing or reviewing laws, regulations, policies, health departments should really be looking at or looking beyond the usual suspects of, for example, state laws around vaccinations, tobacco regulations, or substance abuse and misuse. These are huge public issues that we hear a lot about today, but again, really thinking broadly beyond the regular or what we typically think of public health. This is an opportunity for health departments to think broader in terms of health equity, discrimination and racism, housing, transportation, all of which impact the population's health. Also areas like corrections, education, zoning, and civil rights. It's important to note that Domain 6 does specifically address health equity. It's mentioned a number of times, so really looking at the discriminant impact of public health laws on certain communities or populations will definitely be important here. So today's webinar specifically focuses on Standard 6.1, reviewing existing laws and working with governing entities and elected or appointed officials to update as needed. While the title of this standard talks about existing laws, the measures in Standard 6.1 also address proposed new laws. In this standard, FAB acknowledges that public health laws should be current with public health knowledge, practices, and emerging issues in public health. Therefore, outdated laws or laws that do not reflect evidence-based or promising practice may need to be revised. To effectively revise and update laws, health departments must have the legal capacity to review laws and assess them for recommended changes. Health departments should also be collaborating with stakeholders, subject matter experts, and decision makers when needed. So I'm giving a background of Standard 6.1 and Domain 6 right now, but our presenters today will be sharing their experiences, tools, and strategies for starting and approaching this work. So let's take a deeper dive into Standard 6.1. Measure 6.1.1 requires that laws be reviewed in order to determine the need for revision. Again, it's important to remember that health departments must be familiar with public health laws as well as laws that are not specific to public health, but have public health implications. So these laws may not be within the authority of your health department. They may be within another governing agency, but if it has an impact on law, the health department should be involved. The law being assessed may be enforced by another agency. Assessment of laws should consider the following: individual or community cost, inconvenience, impact on systematic health inequities, regulatory alternatives, and of course the public health program benefits of the law. So FAB has set out some requirements for reviewing laws. First is the consideration of evidence-based practices, promising practices, or practice-based evidence and the impact of the law on health equity. Second is the use of model public laws, checklists, templates, or some other standard outline or guide. And this could be developed by your health department or by others. So for example, a health department may use the federal FDA model code as a guide in reviewing and evaluating amendments to regulations. One of the other requirements for reviewing laws is input from key stakeholders and partners. These may be subject matter experts from within the health department, but also outside the health department, so community members, decision makers, and those who have experience in the area. Finally, FAB requires a collaboration with other levels of governmental health departments. For example, state health departments must show that they collaborated with tribal or local health departments in reviewing laws that may impact those tribes or local health departments. FAB also requires that health departments have access to legal counsel, review, and advice as needed. So while most health departments may have legal counsel on staff, you might not, and you'll only have to show that you have access to legal counsel. For example, if you have access to legal counsel through the Attorney General's office. So that was Measure 6.1.1. We'll move on to Measure 6.1.2. This measure requires that information be provided to the governing entity and/or elected or appointed officials concerning needed updates or amendments to current or proposed new laws. So here FAB is assessing the health department's efforts to provide advice to the stated parties on the public health impact of the content of new laws and changes to current laws. So FAB recognizes that health departments are experts on laws that impact the public's health, and they therefore have a responsibility to share findings and recommendations for amendments, meaning revision, creation, and deletion of laws. It's important to note that not all legal reviews or policy recommendations will result in change. I know that that's always the end goal, but really what we're looking at here is that the health department show that it provided information for consideration by elected or appointed officials so they can make informed decisions. We can only do so much, but as long as we're providing relevant information that can help decision makers make informed decisions, that's really the end goal here. It's also important to note that FAB requires written review of current or proposed laws that are submitted to the governing entity. So of course, in-person conversations during regular meetings are great, but for the purposes of accreditation, showing that there was written recommendations as well. So this is a somewhat deeper dive into Standard 6.1. I'm happy to answer any questions at the end of the webinar after our presenters. I'm really excited for them to share their experiences, tools, and how they met these requirements, or how you can sort of take an approach to working with different stakeholders and assessing and reviewing laws. So I'll turn it back over to Jamie. Thank you.
Great. Thank you for that overview, Lea. And with that, I'm going to go ahead and turn it over to our first presenter, Katelyn Lange from the Washington State Board of Health and the Governor's Interagency Council on Health Disparities, who will now talk to their use of health impact reviews. Thank you.
Good afternoon, everyone, and thank you, Lea and Jamie, for the invitation to participate in today's webinar. I'm really excited about this opportunity to share the information on the health impact review work we're doing at the Washington State Board of Health. In addition to conducting health impact reviews, I also provide general research and policy analysis support for both the board and the Governor's Interagency Council on Health Disparities. So quick overview during this presentation. I will cover the history of our Health Impact Review, or HIR, tool, the HIR framework and a high-level example, and the benefits of using this tool. Thank you. So our Health Impact Review, let me provide a quick history. So for context, the Health Impact Review tool arose from the Washington State Senate's work to address health disparities. Senator Rosa Franklin championed the efforts, co-chairing the Joint Select Committee on Health Disparities in 2004-2005. The committee recommended developing tools that systematically review key policies as they are developed to learn upfront how they might ameliorate or exacerbate the root causes of health disparities. Senator Franklin co-sponsored the 2006 state legislation, which created the Governor's Interagency Council on Health Disparities, and gave the State Board of Health the authority and responsibility to conduct health impact reviews in collaboration with the Council. The committee's recommendations adopted a social determinants of health approach, or what we would now consider a health and equity in all policies approach. So thinking about the framework and moving, what is a health impact review? So a health impact review is an analysis of a specifically proposed legislative or budgetary change to determine its likely impacts on health and health disparities. In practice, we assess whether the proposal would have an impact on health in general, and if so, we assess whether there might be disproportionate impacts on different communities. We look at health equity issues for any potential impacted community, and this slide provides a few examples. For the Health Impact Review, only the governor or a member of the legislature may request an HIR. And during the legislative session, by statute, we must deliver HIRs within 10 days. So although things are moving quickly though, so requesters often ask for them sooner. During the interim, we have additional time to complete reviews on draft proposals and some more in-depth analysis. I know that many of you are familiar with the concept of health in all policies, and that's really our goal with HIRs, but even more than that, we have a health equity in all policies goal. Today I'm going to walk you through the HIR process using Senate Bill 6529, Protecting Agricultural Workers and Community Members from Pesticides. This example was completed during this 2018 interim and took longer than 10 days. So a quick overview of our process. Once a health impact review has been formally requested from a legislator, we begin an objective review of the scientific literature and use the evidence to develop logic models. So in some cases, these pathways are pretty direct, and in other cases, there are a number of intermediate outcomes between the proposal and health impacts. So for example, Senate Bill 6529, our summary of the provisions. First, it would require the Department of Health to create and maintain a publicly available pesticide use reporting system. Second, it would require DOH to notify all child care centers, schools, and individuals requesting notification within a quarter mile of the application site at least 2 hours before the pesticide application occurs. So once we know the overall, understand the overall provisions of the bill, then we conduct an initial search of peer-reviewed literature and review committee testimony and documents relevant to the bill. With this information, we draft a potential logic model, which we test by reviewing additional literature and consulting with subject matter experts. So those subject matter experts might be from the Department of Health. They also may be from other state departments or local authorities. So our initial review of Senate Bill 6529 found that the bulk of the bill text and public testimony focused on the specifics of the notification system. So we thought that would be our primary focus of the review. However, in searching the literature, we could not find evidence evaluating the effectiveness of the advanced notification of pesticide application. And in addition to a lack of published literature, we learned from key informant interviews that an advanced notification system poses many challenges both for state agencies as well as growers and applicators. So interviewees also shared potential unintended consequences that may result from the notification system outlined in the bill. For example, the bill required growers and applicators to notify Department of Health 4 days prior to application to allow the department time to notify daycare, schools, and interested individuals. But growers and applicators shared that it's impossible to know that far in advance if weather conditions will be safe to apply because of the various factors. Some interviewees voiced concern that the described notification system has the potential to worsen health outcomes. For example, one interviewee expressed concern that applicators may be pressured to apply in less than optimal weather conditions because a notification had already been submitted, which could increase the risk of pesticide drift. Other interviewees were concerned that the notifications may not benefit those most at risk of pesticide exposure, namely farm workers and their families. So due to the lack of published literature and the potential for unintended consequences, we could not draw a logic model or apply our strength of evidence criteria to evaluate the advanced notification pathway. Instead, in our final report, we outlined the unintended consequences and the potential difficulties in implementing this type of system. However, there was sufficient evidence for the pesticide use reporting system provision. So here is this diagram documents the logic model we created for the pesticide use reporting system. And as I said earlier, sometimes they're short, sometimes they're longer. So we used published literature and interviews with subject matter experts and key stakeholder groups to inform the logic models. Each question mark along the pathway represents a relationship that needs to be researched. So we review the literature on each research question in order to determine if there's evidence that that relationship exists, and if so, how strong that evidence is. During the legislative session, we depend almost entirely on the scientific literature. Although we do consult with stakeholders, we don't do any primary data collection. During the 2018 legislative session, Senate Bill 6529 was amended to establish a work group to improve pesticide safety. So the bill's sponsor extended our deadline and asked that we provide findings to the work group. This extension allowed us to expand our review and to conduct 18 key informant interviews, including 11 informants from pesticide regulatory and state agencies in California, Oregon, and Washington, 4 interviews with representatives from pesticide applicators and growers associations, 2 informants representing academia, and 1 informant representing farm workers. We also spoke with 3 subject matter experts from the Washington State Department of Health, Office of Environmental Public Health Sciences. When appropriate, we supplemented available research with information provided by key informants. So once we have all of that information, we take our strength of evidence criteria to really look at what can we say about the evidence currently available. So we developed criteria to rank the evidence and then piloted them with Master of Public Health students at the University of Washington. The goal of these criteria are to create objective guidelines that multiple analysts could use could apply to the same body of evidence and come to the same conclusion concerning how strong the evidence is. Some groups in Washington, as well as other agencies, have already expressed interest in using these criteria when they do their own health impact assessments or HII-like projects. When a pathway does not fit within established criteria, the HIR team collectively reviews the evidence and establishes a new characterization of the evidence. This interim, we're refining and formalizing definitions for expert opinion, informed assumption, unclear impacts, and indeterminate. So once we have our strength of evidence and we've looked at all of these pieces, you can see from the key at the bottom of this slide that in the logic models, the thickness of the arrows reflects the strength of evidence. So this first relationship required that we make an informed assumption based on interviews conducted with state agency informants from Washington and California and information available on state websites. Using our criteria to rank the strength of evidence, we found that the evidence for this particular HIR was either fair, the thick dashed arrow, strong, the thinner arrow, or very strong, thicker arrows. Within the body of the HIR, we describe the evidence used to determine the strength of evidence listed on the logic model. So how do we go about taking all of this information that we've collected and evaluated and putting it in a format that's really accessible? So we wanted to create a product that was easily accessible to an audience that includes legislators, but would also provide strong and detailed support for the findings of the review. So we streamlined the format of the HIR by moving away from a standard report format and instead creating a deliverable where the body of the document is very concise, and we purposely modeled the HIR document on other briefings that legislators receive and agencies submit, for example, bill analyses. The one-page executive summary provides legislators with a tool that allows them to quickly highlight the important findings from the review. The analysis of health impacts provides more detail about the evidence evaluated for each pathway reviewed. And then at the end of the review, we include annotated references, which provide the legislators and staff with concrete evidence supporting the findings of the HIR. We received some positive feedback on this format from legislators who requested reviews, as well as suggestions for how to continue to improve the HIRs. Notice that within this format, you do not see policy options or recommendations. The goal is to provide a health lens complete with evidence to inform legislators' decision-making. However, the tool was consciously developed not to include recommendations, in part because maintaining our neutral position is particularly useful when working on contentious or partisan policy issues. Additionally, we don't have time to explore all policy options, especially when we're working within that 10-day timeline. So we don't want to make a recommendation based on our analysis of one policy option when there are others potentially that could affect health and equity. So how has the use of this tool grown and benefited Washington? So we started, the work was initially funded from 2006 to 2009, during which 7 HIRs were completed. And then funding for HIRs was suspended from 2009 to 2013 due to the recession and its impacts on the state budget. It was refunded in 2013, and since November of 2013, we've completed 59 HIRs. In addition, a number of legislators have indicated that they were planning to make a request, but decided against it when we told them that we had a queue of requests to complete, and we wouldn't have time to get to their bill for several weeks. So the demand is actually beginning to surpass our capacity. This year we had 1.5 FTE working on HIRs, myself and one other half-time analyst. So this chart shows the growth in requests that we've seen since 2007. Since funding for this work was suspended for 2 biennia, I excluded 2010 to 2012 from this graph. And 2009 and 2013 are also outliers, as this work was only funded for 6 months in each of these years. Also note that in Washington, legislative sessions that fall on odd number years are 105 days long, while in even numbered years, the legislative session runs just 60 days. Therefore, when we compare growth between years, we look at odd years and even years separately. However, you can see from this chart how much traction this work has gained and how the demand for reviews has increased since funding was reinstated. And then, there we go. Health impact reviews by topic area. This slide shows just how broad the different requests we receive are. You'll notice that requests related to education, criminal justice, and substance use make up 50% of our reviews, while the other 50 are fairly well split among other social determinants of health. All of the completed health impact reviews are publicly available on the State Board of Health's website, which I have a link to on the final slide in my presentation. And I'm thinking about outreach efforts. So our primary focus historically has been on legislators and their staff. And legislators are generally really excited to learn about the HIR tool. I've heard countless times that this is unlike any tool that they've had access to before. So we've really focused our efforts there. Before session begins, we request meetings with legislators, those who are new or who haven't used the tool before, to introduce the tool, and we email previous requesters to remind them of our work and how it may support their policy work. Our staff also reviews pre-filed bills prior to session to identify proposals that are a good fit for an HIR. We then contact legislators to share information about the health impact reviews, discuss how it may be helpful for their bill, and these outreach meetings often result in requests. This session, our outreach to the governor's policy advisors resulted in our first governor-requested health impact review. And moving forward, we plan to share the tool with other policy advisors within the governor's office who specialize in areas not traditionally considered health-related, like transportation. This year, we also received feedback from legislators that it would be helpful if nonpartisan committee staff and caucus staff knew more about the tool and could recommend it to legislators as they draft bills. We also received suggestions to reach out to the state agencies' legislative liaisons. So we're continually learning how best to inform legislators about this tool that's available to them. And part of that work is building relationships at different levels of government and between disciplines. So how have HIRs been adopted into decision making? So the health impact review continues to be normalized. Aside from receiving requests from a larger number of legislators, we are also often asked to distribute the HIRs to committee members and to testify on the findings of our health impact reviews at public hearings. So we testified 8 times during the 2018 legislative session. HIRs have also been referenced on bill reports and mentioned in bill briefings by committee staff, cited by legislators during public hearings, and mentioned in media reports. This session, we also started sending a memo to the governor with the HIR findings as he contemplates signing or vetoing legislation. We sent 4 memos to the governor during the 2018 legislative session for bills that passed. All 4 of those reviews were completed in previous years, which I think is important to highlight because we need to remember that legislative change is often a slow process and that the HIR tool can be used to help develop and build evidence for proposals over time. The governor's health policy advisor also used information provided in the HIR for communication purposes and incorporated excerpts from the executive summary into a broader memo to the governor. HIRs are also shared with contributing stakeholders, including state agencies, who may use the findings to inform policy. This session, we shared relevant analyses with the Office of Superintendent of Public Instruction and the Washington State Departments of Health and Agriculture. In regards to our review of Senate Bill 6529, Department of Health staff asked our HIR analysts to participate in initial work group planning and to present our analysis to the work group to inform their process. Department of Health staff have also used HIR findings from our analysis of prohibiting the sale or gift of tobacco or vapor products to a person under 21 years of age, also known as Tobacco 21. Staff from the Tobacco and Vapor Product Prevention and Control Program have incorporated findings from that analysis into their discussions and communications with regional and priority population contractors who have shared in turn that they share that information with their partners and community leaders to educate decision makers. And according to staff, at least one priority population partner referenced the HIR in a public hearing, and another appreciated that the HIR provided support for some of the community expressed concerns. So we see how it's being used by multiple stakeholders. So benefits of HIRs. Legislators consistently share they appreciate the evidence evaluated and presented in the HIR. One senator shared that I believe the legislature is moving away from emotional decision making and is heading in the direction of making decisions based on science and evidence. And along with that idea of objective evidence-based analysis, multiple legislators have also expressed that they feel the HIR tool adds weight and credibility to their proposals because it provides that objective review from the State Board of Health. One senator shared that by providing objective evidence, and because the board doesn't necessarily have skin in the game or a personal agenda, she believes legislators are more likely to listen. And we believe the board is viewed as unbiased in part because when we testify on health impact reviews, we always sign in as neutral. We want legislators to use the findings to inform their decision making. However, again, the tool is not developed to provide recommendations. One representative also found it particularly helpful to see potential short-term and long-term outcomes that could result from the legislation and felt that the long-term outcomes helped other legislators see the impact further down the line. Legislators have also shared that they use HIRs as an education and communication tool. One representative mentioned, I have to learn about many different topics very quickly, and the Health Impact Review tool was helpful in having conversations with many different people and stakeholders about the issue. Similarly, a senator indicated that he asked his staff to incorporate content from the HIR into his committee testimony. So the strength of evidence criteria really provides an easy way for legislators to characterize the associations, and in addition to the summary of findings, our detailed annotations provide a deeper dive into the evidence reviewed. One legislator shared that although the bill reviewed did not pass, he plans to use the statistics and references provided as he and his staff draft future legislative proposals during the interim. Legislators have also shared that HIRs provide a different way of thinking about an issue, particularly one that's not clearly health-related. So for example, one senator explained that the HIR articulated the connection between the policy, which on its surface had nothing to do with health, to a significant health outcome. And that was really helpful in having conversations with different stakeholders and other legislators. So our lessons learned. A health impact review is one tool to implement health equity in all policies approach. The strategies and approach we use can be incorporated into existing work. Standardizing the application of strength of evidence criteria allows for objective evidence-based analyses, and policymakers appreciate the focus on evidence. Senate Bill 6529 is a perfect example of why it's important to proactively engage subject matter experts and key stakeholders to identify research gaps, consider unintended consequences, and understand the nuances of a specific issue that may not be included in the literature. We recognize that some information is currently best learned through listening to lived experience, so we try to piece that in when available into our approach as well. It's important also to develop tools and approaches with your goal and intended audience in mind. So our staff has updated the HIR format over time to meet legislators' needs, and we're constantly asking for feedback. And like anything new, implementing HIRs takes time to develop trust. So historically, legislators have asked for fiscal notes on a routine basis because it's a known tool. HIR adoption has been relatively slow but steady. It requires ongoing outreach and reminders, in part because legislators have so many priorities and stakeholders to address. But what we've seen is being intentional and consistent has allowed this tool to grow and support policy decisions. Additionally, it's also important that HARs are understood as a nonpartisan objective tool. In Washington State, we found adoption was quicker among Democrats, but through steady outreach, our staff has increased adoption among Republican legislators as well. So I hope you find these lessons learned and strategies discussed useful for assessing public health laws and engaging with stakeholders, elected officials, and subject matter experts. And I am happy to answer any questions at the end of this presentation. And here you can find this link goes to all of our health impact reviews where full reports and executive summaries are available. Thank you so much.
Well, thank you, Katelyn. That was so much great information you shared, and I really, really appreciate your sharing of the feedback that you received from your state legislatures, as I imagine others, if they take this approach, will have a similar experience of having to educate them, inform them, and get them on board with this. But really appreciate you sharing that and your lessons learned from this. If you have any questions for Katelyn, please feel free to use the chat box, and we will get to those at the end of this presentation, at the end of the webinar, excuse me. But without further ado, I would like to turn it over now to Dawn Hunter with the New Mexico Department of Health, who will be talking about their strategies for updating their public health legal infrastructure. Thank you, Dawn.
Thank you, and I also appreciated Katelyn's presentation and think it's great to consider. I look at Washington a lot and what they're doing, and we in our fiscal impact reports have a health disparities section that I think is really important. So I am going to talk to you about some specific work that we've done here to update New Mexico's Public Health Act and some other work that we do on an ongoing basis. So what I'll do is talk about Domain 6 just from New Mexico's perspective, and then give you a couple of examples of New Mexico's approach to this particular domain and Standard 6.1, and that is Senate Bill 223 from the 2017 session, and then I'll talk more generally about our policy development process here in the department, and then share some ideas I have regarding implementation. So I share this slide because a lot of the work I do at the department is focused on developing policies and enforcing laws in the department. Some health departments, New Mexico included, don't actually have enforcement authority over a lot of areas. So we have a lot of conversations about how we partner with others in enforcement of public health law. And it's an important part of the work that we do to, around accreditation and to be reaccredited, which is coming up soon for us. So policy development helps us to guide public health practice, and from my perspective, it's important to do so within the established legal framework, considering what our laws do to promote health and how we can comply with them. When I first joined the department, the accreditation process was underway, so we were not yet accredited when I first joined, and so I was part of those conversations that we had about our responsibility to educate the public about public health laws. What did that look like? What are public health laws' meaning and purpose, their benefits, and what are the compliance requirements? And that's what Domain 6 is all about. So again, just to make a note from New Mexico's perspective, since this was already covered, Domain 6 in particular for the Department of Health here in New Mexico was really challenging. So one, on the one hand, because we don't have enforcement authority over some areas and we have agreements with other agencies, but also we had a lot of conversations about how we document what we're doing to review laws and update them. And we did have really quality documentation, but there were questions about how do we make this uniform and sustained over time. And I put Standard 6.2 on this slide because from my perspective, when you're having a conversation about reviewing laws and updating them, communication is an important part of that, and educating people on the benefits of what you're proposing or what you're even having a conversation about is inextricably linked to Standard 6.1. So those are important things from our perspective, and those are considerations that we took into our development of documentation for when we became accredited. So Standard 6.1.1, reviewing existing laws. So I'm going to start out, as I mentioned, with a specific example, which was New Mexico Senate Bill 223 from the 2017 legislative session. On this slide is a very short timeline of what we did. So we conducted, specifically for accreditation, we conducted a formal assessment of New Mexico's public health laws, and that was in 2013. I joined the department in 2014 as a public health law fellow, and basically all of my work during that fellowship year was dedicated to figuring out what to do with this assessment. What we ended up doing in a nutshell was introducing Senate Bill 362 in the 2015 legislative session. Similar to Washington, we have alternating short and long sessions. Our short session is 30 days and our long session is 60 days. So Senate Bill 362 in 2015 was unsuccessful for reasons that had nothing to do with the merits of the bill. We discussed it and reviewed it for the 2016 session, but since 2016 was a 30-day session, we decided that we would just look at reintroducing it in 2017, which we did. And this time we were fully successful, and it was signed into law on April 6th of 2017. So why did we want to update laws in the first place? Not just because of accreditation. So one of the things that we looked at is that a lot of statutes are quite old and really reflect what was going on in public health at the time that they were enacted and not necessarily what the current state of public health is. This is particularly evident with TB, not just in our state but in other states. We also had the Turning Point Model State Public Health Act that was issued in September 2003 that we used as a standard, and that was actually part of the assessment that we had conducted. But then also that coincided with the Turning Point initiative, which was funded by the Robert Wood Johnson Foundation to transform and strengthen the legal framework in states. So as part of that program, 14 states were originally selected to receive a 2-year grant to develop a plan for modernizing and improving their public health system. New Mexico was one of those states that was originally selected. In the end, I think we were the only one of the 14 states that did not get funding, but it was important because it started a conversation in all of those states about how we have an approach to reviewing and updating public health laws. Since the Turning Point Model State Public Health Act was developed, more than 25 states have passed legislation based on the Model Act. One area of particular impact is quarantine and isolation, and I'll talk a little bit more about that later. The project ended sometime around 2007 in terms of tracking and assessment and analysis. And just very specifically, 19 states had introduced legislation as an example based on the Model Act section on quarantine and isolation, and 17 of those states had passed legislation on quarantine and isolation at that time. So it was really good in terms of providing language for states to consider and use, and made it a little bit easier for states to put forward proposals. So the details on the assessment. So our report was actually conducted by an outside party, so that it was called New Mexico's Public Health Law Review and Recommendations. It was completed by the Public Health Law and Policy Program at the Sandra Day O'Connor College of Law. Professor James Hodge was the lead on that, and Vita Calmer, who was also a fellow, public health law fellow in the same program that I was in, but she was in the previous cohort, and Kim Widener, who was an attorney with the Network for Public Health Law Western Region, were all part of conducting that assessment. It was based on all laws that were current through April 1st of 2013, and again, used the Model State Public Health Act as a comparison and reference. So the mission of this Model Act specifically was to transform and strengthen the legal framework for state public health systems. Over several years and with many collaborators, including 5 states, various government agencies, the Institute of Medicine, and more, the Model State Public Health Act was developed. The Act has 9 substantive articles, and for us in New Mexico, it really served as a model of an organized series of provisions with recommended language to facilitate the provision of essential public health services and functions. That's how we viewed it. It's important to note overall that based on this assessment that we were in great shape relative to other states, and it was noted that we had enacted many groundbreaking laws to improve public health, particularly around overdose prevention. In New Mexico, 4 primary agencies are responsible for health laws. That's the Department of Health, the Environment Department, our Human Services Department, and our Department of Homeland Security and Emergency Management. We decided to really focus on impacts to the Department of Health, but these other agencies are also really important partners. So here on this slide are the recommendations for our particular assessment and ways that we could consider moving forward with the recommendations, either reorganizing or restructuring as a way to improve access and understanding of the interrelatedness of the provisions, revising laws to allow the law to reflect best practices, repealing provisions that serve no public health purpose, or ensuring that the law is current and uniform, and that it reflects what is or isn't being done in daily practice. We also looked at what our legal powers were and responsibilities in our enabling statute. We looked at not having laws that were based on specific conditions, but looking at a more broad framework for conditions of public health importance. And we also looked at how we could clarify our agency mission. So this slide shows an example of a table that's included in our assessment that's based on the Model Act. So in the left column is the article in the Model Act, which is 5-101, Prevention and Control of Conditions of Public Health Importance. And on the right column are all the laws in New Mexico that would arguably fall into that same article in the Model Act. So one of the things that was recommended was we could potentially compile all of the provisions that had to do with the prevention and control of conditions of public health importance into one comprehensive law. This would be one way that you could facilitate access, to understand how key provisions and programs work together, potentially eliminate duplication, and perhaps expand the scope by removing limitations that were based on very explicit or condition-specific provisions. As I mentioned, this is not what we decided to do. We really wanted to focus on just the laws that were related to the Department of Health and our specific responsibilities. And we also really had a conversation about cleaning up the Public Health Act versus making substantive changes. So we thought, what is our objective with this assessment, and what do we really want to accomplish? And in the end, we thought we were really in a good position to clean up the Public Health Act and modernize it. So what was the strategy? When I was a fellow, as I mentioned, I spent almost my entire fellowship time working on this project. I did have a couple of other projects, but this was my main one. And the first thing I did was meet with stakeholders. The question was really, here are these recommendations. What makes sense to you? What do programs need? What do employees see in their work on a daily basis? How does this impact any of our external partners? And we really use that feedback, or I use that feedback to analyze and categorize the recommendations in the assessment. And what I decided to do was break them down essentially into 5 categories. There were things that required us to have new statutory language, things that were moderate changes, minor, things that we could accomplish through regulatory action, and things we wanted to repeal. A couple of examples. So for new language, in Senate Bill 223 that was passed, we defined testing and screening. Those were not previously defined in law. We also, completely new language, have power now to issue a public health order for 24 hours. And that's something that was new and didn't exist in the law before. A moderate change that we considered was revising the health planning process for our state health improvement plan, which was already in statute, but we wanted it to align more with accreditation. A minor change that we considered was updating STD to STI. And as an example, we had previously done that in New Mexico when venereal disease went out of fashion and was updated to STD in law. So we thought we had a basis for saying, hey, we just want to clean this up. It's not a big change. And then for repeal, we also looked at examples like we had a provision that prohibited school employment of individuals with a communicable disease. And for various reasons, we thought this law doesn't work anymore, and we suggested repealing it. So after I developed that list and categorized all the assessment recommendations by these 5 areas, we prioritized that list based on a number of factors, some of the key factors being what the interest would be in moving forward with those recommendations, whether or not there was actually a need to do so, and what was the political feasibility. I mentioned the discussion about cleanup versus major substantive change. So we talked a lot about whether or not it made sense to try to make changes that were going to attract a lot of attention and discussion and debate versus changes we thought would just improve our existing law and support modern public health practice. So at the end, we developed a cabinet-level proposal, and I spent a lot of time actually drafting the language that we originally introduced in 2015 with several other people. So communicate needed changes related to standard 6.1.2. So what we did was we had an agency review. Once I had draft language and we decided how we wanted to move forward with the recommendations, we reviewed those with our cabinet secretary, our general counsel, and the policy director, and we considered a number of factors. They're listed here. And one thing that's not listed here, but that's really important, is that we always ask is what are other states doing? It's really important to know if other states have enacted laws and what the impact has been since they were enacted, so we can have some kind of comparison for what might happen here if we did something similar. We also then moved forward with our cabinet level proposal, and we had a discussion at that time about whether or not we wanted to do one comprehensive bill that covered all of the changes that we were putting forward, or whether or not it made sense to do multiple proposals. For example, we made changes to our quarantine and isolation statutes, but we also made changes to our state health improvement plan language, to definitions, and so there was a question about whether those things should be combined. In the end, we decided that they should just be one comprehensive proposal. We packaged it as a cleanup package, and that's how we move forward. But it's an important conversation to have. We then identified a sponsor. In this particular case for this bill, our sponsor in both legislative sessions was an attorney. So he was very interested. We sat down and went through every proposal with him, line by line. But he's also an attorney and legislator who is known for his cleanup bills in the legislature here. And so we thought he was a perfect fit, and he was. He was a great advocate. And one part of what we did was spend time educating other lawmakers. There were a lot of questions about what we were trying to accomplish, and so we spent time having conversations with people about why we consider this to be cleanup, how it would improve the way things are done here, and how they could help support us moving forward. So that was an important part of the process. So on this slide, there are a summary of the key changes that were really important for us, and these, again, were all in one bill. So we had our authorities and responsibilities updated to really reflect our current programs, activities, and the essential public health services. We changed, as I mentioned, to a conditions of public health importance framework instead of having disease-specific laws. Again, new language for us. We have now the authority to issue emergency public health orders for 24 hours for quarantine or isolation. But we also added into that some due process and other protections for individuals subject to quarantine and isolation. We also looked at aligning our state laws with federal laws and national initiatives like Public Health Accreditation. We updated statutory programs like our school nurse programs and EMS to reflect what actually goes on. So with school nurses, for example, many, many years ago, school nurses were public health nurses. That's no longer the case, and we don't have direct supervision of them. That falls under our public education department, but the law had never been updated to reflect any of that change. And finally, again, we made several changes throughout the Public Health Act to modernize terminology. I mentioned STD to STI. We also updated Indian and Native American. Another example is all references to the Secretary of Health are now gender neutral. So those were just minor changes that we thought helped to modernize the law. So what are the benefits of doing this? One is, again, to reflect current practice and scientific evidence. Another, to comply with modern constitutional norms. As I mentioned, that was important with our updates to our quarantine and isolation statutes. Also to clarify our powers and duties. So in our enabling law, or an enabling statute, do our powers and duties reflect the essential public health services? We wanted to encourage discussion among policymakers and community stakeholders about what public health looks like in the state. And most importantly, we looked at this as a way to improve public health programs and outcomes. So how do we incorporate Standard 6.1 into regular practice here in the Department of Health? Well, one thing that we do is that on an annual basis, we solicit programs for policy proposals for the upcoming legislative session. We have a form that we ask everyone to fill out. I thought about snapshotting it and putting it in here. In the end, I didn't, but I'll talk about what's in it. And we ask programs to do these things here. Give us data. Tell us why you want to do this. Conduct a literature review. Give us the policy recommendations, including any budget implications. Most importantly, probably, provide references for all this stuff. And again, really important for us to know what are other states doing. So the same discussions that we had with the specific example I gave you of Senate Bill 223, we do with all of our policy proposals. What type of change is required? Are we talking new language, amending existing language? Do we need to repeal something? We always ask the question of whether or not we can accomplish what we're proposing through regulatory action. One example of that here in New Mexico is we had a bill introduced this 2018 session related to suicide gatekeeper prevention training. And as part of that discussion, we really debated whether or not it was something that we could do through regulation. That bill was ultimately unsuccessful, and so now we are working with our public education department to determine how we might incorporate that into existing regulations. We also, again, ask, what is the need for this? Is there interest from stakeholders? Is there opposition from stakeholders? And is it politically feasible? We develop formal proposals from these proposals that we pull from throughout the department, and we review them with our cabinet secretary, with our general counsel, and with the policy director. And if approved to move forward, we work with our identified sponsors to draft language and to introduce approved legislation. And then we track the status throughout this entire process, including up to and during the legislative session. And we work with stakeholders throughout that entire time to educate them on what's going on, to work with supporters, to have conversations with individuals who might be opposed, etc. So one example I'll give you is the revision of the Pain Relief Act from the 2018 session here. This was a Department of Health initiative. And what you see on this slide would actually be in the Word document that I mentioned, and these are just small excerpts. But one of the questions that came up is here in New Mexico, we have historically had the highest drug overdose death rate, or 1 or 2 in the nation. Recently that's been declining. We were 8th in 2015. I believe we're down to 12th now. And it's a significant problem here. And so we have this advisory group, the Prescription Drug Misuse and Overdose Prevention and Pain Management Advisory Council. That's a mouthful. It's attached, administratively attached to the Department of Health. And this council functions as a central site for review and exchange of information by council members and diverse stakeholder non-members, as well as recommending pain management and clinical guidelines per their responsibilities under the Pain Relief Act. So one of the questions that came up is that we weren't sure that the membership really reflected everyone who needed to be involved. And so our Epidemiology and Response Division put forward this proposal, giving us information that we thought was important to be able to answer any questions posed to us. What is the issue? Our drug overdose death rate. Here's a breakdown by race and ethnicity and the disparate impact. The causes of drug overdose mortality here in New Mexico and why it's important. And then specific to the issue of this council, we also had them look at what are recommendations. So the National Governors Association recommended that key decision makers and priority stakeholders are connected to efforts to engage state levers to reduce opioid misuse and overdose. And then we have the Institute for Healthcare Improvement that identified a lack of coordination of approaches, resources, et cetera, as one of the reasons that the opioid epidemic continues to worsen. And so what our program proposed is revising the Pain Relief Act to add 2 new voting members from the Human Services Department, which is our state Medicaid agency, as well as our Department of Public Safety. Now these agencies had already been involved, but they were not voting members, and we wanted to formalize that relationship. So we looked at all of these factors, and we worked with our sponsor, who actually, a legislator who's known for his work around chronic pain, who is someone who suffers with chronic pain himself. And so he was a great sponsor to work with. And this bill was signed into law, so we actually have now these new voting members. We also added a 3rd member to the council, which has a lot of members, I will say that. We shortened the name of the advisory council to Overdose Prevention and Pain Management Advisory Council. Sounds minor, but it does matter when you have conversations about what this council is and what it does. And it also allowed for the creation of subcommittees. So this is just one example of the approach that we have taken. So other things that we do around Standard 6.1, and again, this can include a variety of documentation. I mentioned formal agreements that we have with other agencies, for example, around enforcement. One thing that we're working on right now is developing an agency-wide rules compendium. This is a list of any administrative rule that belongs to us at the Department of Health. Which program area is responsible for it, the date it was last enacted or last revised, and notes on what we need to do with it. Sometimes we can review it and say everything's current, we don't need to make any changes. And sometimes we realize that we need to update the regulation. Once we have this comprehensive list together and notes about where the status of all these regulations, we are going to implement a regular review schedule. Our policies, our internal policies here, are reviewed every 5 years, are due for review every 5 years. And so we thought we would do the same thing with our rules. Another project that we're working on right now is reviewing and analyzing legislation that was enacted during the current administration. We're in the last year of a second term. And so we have a good amount of time where we can look back and say, what has been the health impact of anything that has been enacted that's health related, not necessarily an initiative of the Department of Health. That's something that can be done during any administration. It's also important from a legal epidemiology perspective. What are the impact of laws on health over time? Another thing we do is we continue to work with partner agencies on regulatory or process changes. A couple of examples that I'll share with you is, I'll just remind you of the example I gave earlier from the Public Education Department on the suicide gatekeeper prevention training. Another thing that we're doing is we're interested in county level alcohol consumption. The reason why being that New Mexico has high alcohol related morbidity and mortality. And so we're working with our Taxation and Revenue Department on information that they collect from counties on alcohol sales. And it turns out, initially this was brought to us as a legislative proposal, and it turns out that this just requires a change to the form that our Taxation and Revenue Department uses to collect this information. So we're working with that department now to make that happen. Another example is in 2017, we enacted a law that would enable crisis triage centers to operate in the state here in New Mexico. And of course, we didn't have any CTCs at that time, and in the process of people developing business plans and trying to get these up and running, we came to the realization that the law actually prohibited certain models of crisis triage center from operating. So in 2018, we worked with partners on a bill that was introduced to amend the law to make it feasible for these other models of crisis triage to operate in the state, and that was signed into law this year. So some thoughts I have about how you can implement this. So one thing that's important is to have a point person or subject matter expert for specific initiatives. I have to genuinely say that I think without the attention that I was able to give to the modernization bill, as I like to call it, that I did work on during my fellowship, I'm not sure that it would have happened on the same time frame. So it was really important to dedicate the resources to make that happen. And I think that's the same with any. If we're really if you as an agency or we as an agency are dedicated to making something happen, you have to have a strong point person to see it through. And that person could be your policy director. It might be someone that's specific to a program, but that's a conversation that you have to have. It's also important to have a process with clear timelines. We do here also incorporate regular review with our attorneys, the attorneys that are assigned to the program, and ultimately our general counsel, and our policy director or any assigned policy analyst. We also try to start well in advance of the legislative session. So here, when we solicit proposals for the upcoming legislative session, we actually start now around May of the preceding year. And so we work on them from May and June through the beginning of the session, which is always in January here. And then the same thing applies to regulatory or policy action, is to just have a process. One thing that we also find is important is to have sound justifications for proposals. You have to be prepared to answer any question that comes your way. And I have found that a lot of the questions that we get don't often make sense, but we have to be able to answer them. And so when we ask people to submit proposals to us, we ask for a lot of information because we need to be prepared. And that's an important part of the process. And then, of course, for accreditation, document what you're doing. So we have forms that we use throughout the department to solicit legislative proposals. We have our tracking forms for our policies and for our rules. Those are all things that we will use as documentation if it is appropriate for our reaccreditation process. On this slide are some resources that I use specifically when looking at modernizing the Public Health Act. I love Law Atlas. It's one of my favorite websites because I use it to see easy access to statutes and regulations in other states around a particular topic area. So it's a way that we can answer the question, what are other states doing? I used it in particular For reporting statutes, I also used it for privacy statutes and HIPAA-related laws. A couple or 3 articles in particular that I looked at as we were having a conversation about why we might want to move forward with the assessment recommendations were how many other states had accreditation prerequisites in statute, and what did that language look like? So that article was very helpful, but also just general research in that area. We also looked at a 50-state assessment of public health enabling statutes to see how many state enabling statutes reflected the mission and essential services of public health, and that was part of our impetus for trying to do the same thing. And we also looked at transitions in state public health law, an analysis of state public health law reform since the Turning Point Model State Public Health Act. One of the questions that we got quite a bit was, why do we care about the Model Act? Well, here's been the impact. And so we were able to research this, several other articles as well, on what the impact of the Turning Point Initiative had been and how many other states had implemented legislation based on the Model Act. There is a document that I reference here. That's the legislative matrix table. It's from the Center for Law and the Public Health. It's actually quite old. It was last updated in 2007, which is about the time that any kind of formal tracking or assessment of the Turning Point Initiative was completed. And so an example is here on this slide. And so what you see on the far left column is the section in the Model Act, so 5-101, Prevention and Control of Conditions of Public Health Importance. In the middle is every state, and the empty square or checkbox is whether or not it was introduced, and the black square checkbox is where it was actually enacted. And so this exists. This particular document has the entire Model Act laid out like this, and all of the states and whether or not states had introduced or enacted legislation based on the Model Act. I share this because it was helpful for us, particularly around quarantine and isolation. I mentioned, 19 states had introduced legislation, and 17 of those states ultimately enacted that legislation using the Model Act language. That was part of the conversation we had with other lawmakers about that when we put that idea forward. But I also share this with you because it's something that you can do with any subject area. An example from the most recent legislative session for us is around Special Olympics. We had a question about how other states fund Special Olympics, whether or not funding comes through a state agency or if it's run through some combination of other funding. And so we can do a table. We did a table just like this. Does a state have a state agency that receives funding for this and or not? And so we did the same kind of thing. And so you can do this, again, with any kind of law that you're considering, looking at how many other states have done something similar and what does their language look like. So that concludes what I have in terms of this particular presentation. I'm really excited about the policy process that we have here, and so I'm happy to answer questions about that, and I thank you for the opportunity to be on this webinar today.
Thank you so much, Dawn, for that presentation. I think a couple of things that I personally learned and appreciated about your approach is kind of making minor changes can actually lead to big impact, and so I think that's one thing that we oftentimes forget when we are focused on public health law, thinking grandiose, when it doesn't necessarily have to be. And also, your really kind of data-driven approach and working with stakeholders a lot to move this work forward. So thank you so much for sharing New Mexico's approach to this work. And with that concludes our 2 presentations, but I do have some questions for folks that have already been submitted to the chat box. If you have others, please do use the chat box feature to enter in those questions for any one of our presenters. And with that, I have the first question ready for Katelyn. So Katelyn, how did Washington initially launch the HIR initiative, given fiscal notes were the common tool used by legislatures?
Yeah, so there really was no big formal launch. Rather, staff members who were developing the tool conducted outreach directly with legislators and their staff. And since this came from statute, the development of this tool, we also worked closely with a few champions within the legislature. And these individuals made the first few requests, shared the tool with other legislators to build knowledge of our work, and really kind of made inroads for us in the beginning. And then that's how we've continued our outreach with legislators, really having those conversations about what we're doing. And now we're transitioning into the approach of doing that outreach with staff members from the caucus staff and other staff that have been identified by legislators.
Great, thank you so much, Katelyn. My next question that I have is for Dawn. So Dawn, a question for you. Did you receive any pushback when proposing these changes? And if so, how did you address that? But if not, was it due to the approach that you took, or do you think there are other reasons for why you did not receive pushback?
We did actually receive some pushback. I think the original version that was introduced in 2015 is a good example. We had a provision in there that would have changed our requirements around our statewide immunization registry to make it, I believe it was to make it an opt-out rather than an opt-in. And there was a lot of confusion when that came out that we were changing the requirements for vaccination. And so we actually met with our sponsor and several community partners who were upset about these particular changes and had a conversation with them about what we were trying to accomplish versus what their perception was of what we were trying to accomplish and what we thought the impacts would be. In the end, we decided to take that out, and we requested that it be removed in one of the committees before it went to the floor for a vote. That was important because we also at that time had a conversation about that particular change that was being proposed back to the question of need. And so in the end, one of the factors in our decision was by putting that change in there, we probably brought attention to something that wasn't actually a problem in the state the way it was currently written. And because it created confusion about immunization requirements versus the immunization registry requirements, we didn't really think that it would be worth bringing all that attention to and negative attention to this particular bill and potentially weighing it down, which is why we decided to request to have that section removed. So once that was removed, we didn't receive any additional pushback on the bill, and during the 2017 session, we did not have any pushback. But we did a lot of work talking to legislators outside of committee about what we were trying to accomplish, which I think is also an important part of the process.
Thank you so much for that response, Dawn. Very helpful to hear kind of approaches and lessons learned, and included when you do receive pushback or come up against some barriers. All right, I have another question for Katelyn. So Katelyn, it sounds like the value of HIRs has been strongly demonstrated to legislators in your state. Have there been conversations with them about providing additional resources to expand the capacity to conduct them?
Yes, so we do recognize the need for additional capacity, especially as we have to let legislators know that there is a queue. So as a state agency, we submit our budget request through the governor's budget, and our most recent request asked for one additional FTE, and we received funding for an additional 0.5 FTE. So that's previously, this work was being done by one analyst, and now we have 1.5 FTE for this. So it's moving forward, and we look forward to see how this is going to progress. And we also recognize that our capacity really needs to be based on what legislators are asking for, and thinking about the amount of time that goes into each of these requests takes about 40 hours. So that kind of being top of mind of this isn't something that we could do for all laws. This year we had, I think Washington State had 1,400 bills submitted and proposed, and we really couldn't do, we don't have the capacity to have this required or have it as prevalent as the fiscal notes, but it is something that we want to really have legislators thinking about when it is most important to use this tool. So I hope that helps.
Yes, thank you, Katelyn. And that was actually, you addressed another question that popped up is how many hours does it typically take to complete a HIR, which you shared about 40 hours per?
That's about right. And we do have requests that have been previously done and we're just doing updates, so that takes less time. But for a full analysis of a new proposal, it takes about 40 hours. And then looking at what I presented today with the pesticide protection bill, that took much longer just based on the sheer amount of research and the amount of time we needed to take to reach out to both departments within the state as well as those who have experience looking at this type of the type of provisions that were proposed this year from other states.
Thank you for that. And again, I'll remind folks, if you have questions for Lea, Katelyn, or Don, please feel free to use the chat box feature to raise those questions. Another question for Katelyn, how can participants identify organizations or agencies that are doing HIRs or similar work in their states? Do you have any ideas on where states can look for similar work?
So our specific HIR approach was developed within our agency. So we have been looking for other examples of this type of work within states, but we haven't found anything specific that kind of resembles our approach. So if anyone finds something within their state, please let us know. We would love to learn more. But we haven't seen this for proposed legislation in the same way that Washington is approaching it.
Yes, definitely use this as an opportunity to share other best practices. One more question for Katelyn. So Katelyn, to date, have any of your HIRs shown potential to improve health indicators?
So I might need a little bit of clarity on what exactly we're looking for in that question.
Sure. So this was a participant's question. So if that participant wants to type in the chat box to provide more information specifically, or I would imagine just kind of like health-related outcomes.
Yeah. So we definitely each analysis does the logic model gets to the point of looking at specific indicators. So we, depending on what bill we're looking at, so for pesticides, we were looking at what are the potential outcomes related to increased risk of cancer, developmental delays for children exposed in vitro, pieces like that in utero. So each analysis is a little bit different. We really have that social determinants of health approach. And so if you look on our website, I think kind of digging through and looking at any piece that you're interested in, that's a really helpful way to kind of get an idea of what the health impact review is capable of sharing with legislators. And we really are tailoring it based on the populations that are most vulnerable and may be impacted by any proposed legislation.
Thanks, Katelyn. That is that I did receive another comment from that individual saying thanks for sharing the response to the pesticides, and just wanted to share that he liked the tailored approach that you all are taking.
I'm so glad that's helpful. Yeah, we really do tailor based on each proposal, because if we look at we try to standardize it completely, then we won't get at those nuances that we may miss if we aren't looking at a broad set of literature and really thinking broadly about each topic.
Thank you again, Katelyn. And I think we'll have time for one more question. So going to Dawn. So Dawn, in your research initially that you started now a couple of years ago, did any states stand out as one where you found good model laws or statutes that you would recommend others look to?
Yeah, that's a great question. Immediately Minnesota jumps to mind. I actually worked with their legislative liaison at their health department and took some of their language regarding employment protection for individuals with who are quarantined or isolated. But they have other great examples too, where they had made updates to their public health laws that I use as examples. I will actually point out New Mexico as an example. Our Public Health Emergency Response Act, or FARA, is considered a model law, and other states have used that particular law as an example. And then it just kind of varied depending on the topic. So Texas and Florida also had some good examples specifically related to TB that I looked at. But Minnesota definitely stood out kind of across the board.
Thank you for sharing that. All right, well, we are just about out of time, so I do want to thank each of our presenters one more time for joining us today and sharing this incredibly helpful information as we all think through how we can meet the requirements for FAB Domain 6 and also just work to make lasting improvements within our states and communities that we serve through law and policy. Again, once again, thank you to Lea Silva, Katelyn, as well as Dawn for presenting on this, as well as our funders and, of course, the participants for your wonderful questions and joining us today. I would like to ask you all one more time to please complete the evaluation that you'll receive at the conclusion of this webinar, and remind folks of our third and final webinar as part of this series, which will focus on enforcing and providing education on public health laws for FAB accreditation, so more focused on FAB Standard 6.2. And a reminder that the webinar 1 on Introduction to Public Health Laws for FAB accreditation, where we heard from FAB, the CDC, as well as the Utah Department of Health, that webinar recording as well as slides is available. And if you have any questions, please feel free to reach out to myself or the Performance Improvement Team at ASTO through accreditation@asto.org. So again, thank you all for joining us, and we'll hope you'll be on our next webinar on May 23rd. Thank you.